Okay. Good morning, everyone, and welcome to DigiLeaders and Value in Health Week Wales. We're just waiting for a few more colleagues to join us, so we'll give it another minute or so before we start the session. Good morning, everybody. My name's Sally Lewis. I'm the National Clinical Lead for Value-Based Healthcare in Wales, and I'm also a practicing GP in South Wales. Today I'm going to talk to you about using technology to support value-based healthcare. Next slide, please. Okay, I'm not seeing the slides progressing. If we can go back to the start slide, please. There we are. Brilliant, it's working. So today I'm going to talk to you about using technology to implement value-based healthcare in Wales. VBHC in Wales is a key policy to support sustainability and good outcomes for the people of Wales, and there's global interest in this topic as well. So what is value-based healthcare? Well, value-based healthcare is about achieving the best outcomes that we can for the resources that we have within the NHS. And that means that we need to understand how we allocate resources to where it has great impact and allocate to different groups equitably and in a way that maximises value for the population, as we have heard Professor Sameer Gray say in the past. Value-based healthcare has also been described by Michael Porter as a function of outcomes over costs. And that encourages us to measure the outcomes that matter to patients and the costs of delivering those outcomes across the whole care cycle, because value for patients cannot be generated by a single organisation such as a hospital or a GP surgery alone. It has to be done from the patient's perspective across the whole care cycle. And so naturally, this leads us into a situation where we need much better information, much better data on cost and outcomes, so that we can understand how best to configure the system to get those good outcomes for patients. And that requires us to work together, whether we're a clinician, a manager, or in finance, or indeed informatics, to do that and to find that sweet spot between what we invest in staff and in new technologies such as medical devices, medicines, or digital health. So what are the consequences of not knowing enough about the outcomes that matter to our patients? And it's odd, isn't it, that in the business of healthcare, we really don't know that much about the outcomes that matter. My favourite Voltaire quote from 300 or so years ago is that doctors pour drugs of which they know little to cure diseases of which they know less into patients of whom they know nothing. Well, you can hope that we've moved on a little bit with evidence-based medicine over the last 300 years, but I would argue that it's still true that we know very little about the true impact of healthcare on our patients. So, for example, we don't understand the effects of multimorbidity when we're extrapolating evidence from a randomised controlled trial on a new medicine. We know very little about patient preference and context, and that's a problem when we're trying to apply standardised guidelines. Do those standardised guidelines based on evidence of varying quality actually speak to patient preference and goals? And that's almost a little bit in conflict with tackling unwarranted variation, which encourages us to standardise and to comply with guidance that is rooted in evidence. There's frequently, therefore, incomplete information and advice for people to make decisions about their care. So, you know, what is somebody like me going to have as an outcome if I choose this treatment or another treatment, or indeed if I choose not to have any treatment at all? We need to be able to reflect far better information on likely outcomes to patients so that they can make much better decisions to support their own goals and context. And finally, we have no way of objectively knowing how people are getting on at home unless we bring them back for follow-up and more follow-up and more follow-up. Not only is that a burden for patients on occasions, but it's really, really challenging for us to meet that growing caseload, for example, in an outpatient setting. And that caseload will continue to grow and grow as multimorbidity increases and technologies increase, which enables us to do more things for more people. So we need to be much smarter about how we deliver care and get the right mixture between face-to-face and remote delivery of care, where we're starting to communicate digitally far more with our patients. So therefore, the vision in Wales, at least, is to improve the health outcomes of the people in a financially sustainable way through the creation of a data-driven system. And we're seeking to provide that timely information back to citizens, patients, clinical teams and organisations to inform decision making. So you'll realise that in creating that data-driven system, we're creating a very complex ecosystem across Wales to enable that to happen, and that's some of what I'm going to talk about this morning. So one of the major gaps in achieving value-based healthcare, as I mentioned earlier, is to understand more about the outcomes that our patients are achieving as a result of the healthcare that we deliver. And yes, that means clinical outcomes, you know, such as whether we have managed to cure a tumour or whether, you know, somebody's blood pressure is coming down, things like that. We need to know information like that, but we also need to know about PROMs, patient-reported outcome measures. So patient-reported outcome measures are questionnaires that are validated, that tell us something about the symptom burden of a disease and the quality of life of patients. And they can be very useful and used in a number of ways. But capturing and using PROMs at scale is very challenging and was originally developed in a research setting. So a criticism of it is that it is too time-consuming, too laborious and too expensive and isn't possible to do at scale. But actually, particularly as our ability to digitally communicate with patients is improving, it is possible to do this at scale and affordably as well. But in order to do that, it needs to be really embedded in direct care because it needs to make sense for patients. There needs to be a value in the activity of itself for patients and also for clinicians. Enhancing electronic communication with patients definitely facilitates the data capture, therefore, and you start to get much better response rates, which of course improves the data quality for analysis later. But when we improve digital communication with patients, it also enables other tasks to be completed by the patient with their clinical team, and therefore further embeds this in normal processes of healthcare. How we then use PROMs either in direct care or subsequently for analysis, is different in episodes of care like, let's say, joint replacements or cataract surgery, compared with how we may use them in a chronic non-malignant disease like heart failure or indeed a cancer. So it's important, I think, to define what we mean by an outcome and a PROM, and that has nuances for how we use them. So an outcome is not just a result or a measure of effectiveness of a treatment. It's a milestone or an endpoint or a consequence which matters to a person. So it's a status report on any given day, essentially. And we need to address issues of collecting that information, linking it to other data for other uses, and then on to analysis, presentation and visualization work, and finally utilization. And of course, making that visible to patients and clinicians in as real time as possible is absolutely key to the success of this endeavour, and we'll come into that a little bit later into the presentation. But how can they be used? Well, at an individual level, they're really useful as a symptom tracker, and many of our patients who have been doing this have found it very useful to track their progress over time, and gives a little bit more objectivity around how people have done after a new treatment has been introduced, or indeed a little bit more objectivity around, let's say, deterioration over a time when we're looking at a chronic disease. And so it can act as a trigger for a key conversation, such as an advanced care plan as patients reach end stages of their disease, but also can support shared decision making. And then when we aggregate PROMs up, yes, we can start to improve through comparing PROMs, although there are some cautions around that, which we'll come to later. It can certainly identify unmet need, and critically, they can support a flexible approach to caseload. So I mentioned earlier about remote communication, for example, in an outpatient setting, and we know that through the pandemic, the need to communicate remotely to manage care has accelerated. So using PROMs as a way of supporting remote management, we start to get a more structured feel for what a patient's symptom burden is, and that's incredibly useful when managing chronic disease at a distance. And yes, we can start to identify unwarranted variation and start to generate real-world information, real-world evidence about in vivo effects of medical devices and medicines, for example. And of course, in order to do that, we need to be risk adjusting the data and linking it to other data fields. So you'll start to see now how this means that value-based healthcare has real implications for digital health. So a little bit more now on digital communication with patients. What else can we do when we start to communicate digitally and enable patients to play a much more active role, not in just participating in their healthcare, but actually leading it and directing it? Well, of course, patient-reported outcome capture, therefore, can be linked to appointment management, whether that's remote or face-to-face. We can start to link this to access to and sharing of the medical record and tests, and really giving patients ownership of their data and enabling them to share it with whom they wish, whether that's a carer or another healthcare provider. It also provides an opportunity for access to clinical advice and flexible communication with clinical teams. However, the issue there is much less to do with the technology, as we know, but more to do with changing of the clinical processes, because we tend to do what we do in the NHS and change can be very difficult at times. And then I guess we can start to finesse this over time, linking it also to the management of chronic disease, wearable technology and self-management resources. So how do we embed PROMs in clinical pathways and use alongside other information? Well, back to good old process maps, I guess. We need to understand in a lot of depth the clinical pathway. Next slide, please. Otherwise, we cannot see opportunities for improvement along the pathway, and we may miss opportunities, for example, to embed PROM or other activity into that clinical pathway. So this is an example of a process map for the collection of orthopaedic PROMs in Wales. And it's really helpful then to identify what is feasible in terms of PROMs capture at any given point in the pathway, how that might link to the technology, whether it is in clinic or remote, and helps us then to devise the correct solution to support that embedding in direct care. If you don't do that, actually you miss opportunities for efficiencies and for really sort of deciding where is the best place to capture the PROM. And it also means that there's a danger that the patient or the clinician doesn't feel the value of it if that is disconnected from the clinical processes. Ideally, we're looking for real-time use of PROMs, and that's a challenge which I'll come back to later. So at the moment, we are extracting our PROM data in Wales directly from source, and that creates a little bit of a delay in terms of data visualization for everyone, really, whether that's the patient, the clinician, or for analysis of larger data sets, because we tend to have a process of weekly extract, and after shredding the data will go into either a BI server to feed our dashboards, and we have a number of dashboards, several of which will be launched this week actually in Value in Health Week if you're interested in logging on to have a look at those. But also the reporting server, which allows us to visualise the individual PROM in the Welsh Clinical Portal, which is where the clinician will see that view, and that will prompt a discussion with the patient about their condition. So delays and clunkiness in that process needs to be resolved, and really the way we're doing this in Wales is to create a national data resource. The NDR in Wales is a major strategic development in our digital strategy, which will create a national repository underpinned by standards, which will allow real-time flow of data into clinical systems and reporting. So absolutely critical in terms of development for embedding this type of activity in direct care, and the only way we're going to get the sort of data quality required is if this becomes part of the normal business of healthcare, and that patients and clinicians feel it's useful and it's normal and routine, so that we get excellent data standards. And also, you know, if we're asking people to collect data, they need to be able to see that data immediately, and this will enable that to happen. So going back to PROMs, one of the challenges, of course, in Wales, and I suspect everywhere else, is that everybody's trying to look at this work, collecting patient-reported outcomes at different rates of acceleration, using different systems from different vendors, some small, some large, and really, you know, quite difficult to harness in terms of harvesting that data to use in the ways that I've just described. So we need to work with vendors to describe common standards for PROMs, and this is, you know, a significant amount of work really, and I'm pleased to say that we're starting to work with people from the Aperta Foundation and others to try and tackle this problem. APIs clearly need to be developed and are being developed to feed the data into the National Data Repository and then out into the electronic patient record or back into a visualisation for patients. There also needs to be a relationship, of course, between local data repositories, so the LDRs in our health boards, so that the same standards are applied and the data can move backwards and forwards to be used either locally, regionally or nationally with appropriate standards and governance, of course. The NDR will also be extremely useful for feeding external registries, external disease registries, and research databases, for example, the SAIL database, the Secure Anonymised Database based in Swansea University. So all this is absolutely critical if we are to make full use of patient-reported outcome measures underpinned by really good information governance standards to support value-based healthcare in Wales. So now I'd like to give you an example of how this may work in a chronic disease, and I want to use the example of heart failure, and my thanks to Navjot Kaur and colleagues in Swansea Bay University Health Board for some of their material coming up. So heart failure is a chronic disease characterised by the graph up in the top left-hand corner there. So at diagnosis, the physical functioning of patients has reduced and patients often present with shortness of breath, fatigue, and other symptoms that are limiting their physical function. And therefore, to achieve the best outcomes for patients, we want a timely diagnosis and rapid optimization of interventions so that the upslope on the curve there is as steep as possible, and we see a rapid improvement in physical function once patients are put on the correct medication and other treatments. And then we see a plateau phase where people, hopefully on the right treatment, are quite stable for most of the time, but then we start to see a period of instability characterised by exacerbations of symptoms caused by the heart failure, and eventually, because heart failure is a progressive life-limiting illness, we see a phase where there is an increasingly poor response to treatment and eventually entering an end-of-life and palliative phase. So patient-reported outcomes can really help us manage patients along this journey and help us to identify where they are along that journey. The example on the right is a photo of the Kansas cardiomyopathy questionnaire, which assesses symptom burden in heart failure. And there are standard time points identified on the timeline on the bottom left there for when we might typically collect this information. Standardized time points is necessary, of course, if you're going to be analysing the PROM data for particular purposes later on, but you can add additional PROMs in between if that's useful for patients or clinicians. So how might we use this, and what does it look like? So these are two visualizations of how PROM data may be used in a consultation to show change over time. The symptoms are mapped here either on the left in a bar chart or in a radar plot on the right. In my experience, everybody has a different preference for how data is visualized, so it's challenging to meet everyone's needs and wants in this regard, but I think there's still a lot to do on how we best present some of this data in a consultation for patients. But basically we're able to see an improvement or deterioration in particular symptoms over time, and that's very, very useful to understand how patients are doing and how their treatment may then be modified. So how else might we use PROMs? Earlier in the presentation, I mentioned that if you aggregate PROMs, they are very useful as a needs assessment, and that's because you can see the symptom burden in your population, in your local area. So this is a real example from South East Wales, where we've picked here 2 questions from the Cancers Cardiomyopathy questionnaire. The first one is around patients reporting swelling in the morning, and the second is around patients reporting sleeping sitting up. Both of these symptoms indicate either uncontrolled or unstable, more severe heart failure. And patients are asked, how many times in the last fortnight have you experienced these symptoms? And their answers are then scored. So there is a range from 1 to 6. And patients who are severe will score highly in that they will report these symptoms every day, and those who are stable do not experience these symptoms at all in the preceding 2 weeks. And what's interesting about this, I think, is that what we see is that 2/3 of patients are stable, and that relates well to the graph that I showed you earlier. But consistently, 15% of patients are unstable, so they have uncontrolled heart failure. Now, the implications of that are that they're at risk of hospital admission and decompensation every single day, and that really helps us to understand how to configure our services. I would suggest we could be lighter touch with the stable patients, but be more intensive with that unstable group, whether that's in terms of intensifying their treatment or in addressing their palliative needs. So if you're looking at reconfiguring healthcare services without having any additional resource, this is a really useful tool to begin to meet patients' needs in a much more intelligent, data-driven way than in perhaps our traditional one-size-fits-all solution. So to summarise, what have we learned about embedding patient-reported outcome measurement and indeed data and digital for value-based healthcare in Wales? Well, burden of measurement needs to be considered, and that's particularly true for patients. So it needs to be meaningful, and sometimes less is more. So avoiding duplication of sending out patient-reported outcome questionnaires and overly long ones is really, really important. Issues related to data quality. So of course, missing data is a real threat to validity, so there needs to be a lot of attention to response rates and understanding what creates good response rates and who are we missing, so who is not responding, and how do we tackle that, and how do we tackle digital exclusion also for those patients who are not able to utilise digital communication with us. Embedding in direct care is an absolute priority. Expert help is needed for PROM visualisation and also analysis. Otherwise, it's very easy to draw the wrong conclusions from PROMs. And we are very fortunate that we have the Cedar Institute to help us with proper statistical analysis of PROMs when that's what we're aiming for. Creating PROM data standards is time consuming and ongoing, and we really need to work together, including with vendors, to make sure that this data is easily extracted and linked to other data for the best use of patients. And patient privacy protections are extremely important, of course. So to summarise further, the key enablers and facilitators are, of course, people, process, technology and data literacy. And people and process more than anything. in order to do this, in order to create significant change and changing the processes as well as the digital transformation, we must include our key stakeholders, and essentially most important in that is patients and clinicians, but on their own they can't make this happen. So the best collaboration of all is when we have patients, clinicians, operational managers, financial managers and informaticians in the same room, looking at those process maps and understanding why this is an important endeavour together. Then the process, yes, we need to process map and look at quality improvement across that process. You can kill two birds with one stone here. And then, of course, onto the technology, developing standards that allows us to transmit data across and between organisations. And still a lot of work to be done on data literacy and not just digital awareness, but digital involvement of boards at an executive level, and giving patients control of their data and a say in how that data is displayed back to them, so that it is meaningful in the ways that we've discussed earlier in the presentation. And so finally then, I hope I've been able to explain to you how a data-driven system which focuses very much on outcomes that matter to patients and understands our costs also across the system in delivering those outcomes so that we can make intelligent decisions about resource allocation. So that's absolutely fundamental, that digital and data underpins value-based healthcare. And then we can achieve value for patients in so many ways by using these techniques to raise health literacy, to support healthy behaviours, and ultimately to support a shared understanding of medicine towards the best choices for patients in their own context, which of course then leads on to much better outcomes for them. We can start to understand how we decrease unwarranted variation and low value care. It's said that about 20% of care is low value. What I mean by that is that it does not improve outcomes for patients. But if we take a purely cost-cutting approach to that, we risk harming outcomes. And therefore, without this data, I would suggest it's incredibly difficult, if not impossible, to safely decrease unwarranted variation and low value care. We want optimum positioning of drugs and devices, so we want to be able to adopt technologies rapidly, but also disinvest when they are not delivering the outcomes that the early research suggested may be possible. And this is going to become ever more important as we have really, high cost targeted medications available, such as cell and gene therapies. So we need to really have a system of collecting outcome measurement for that and feeding that back into the system to reassess where our investments are made. So we're turning the ideal population to a real population by really understanding in vivo what the impact of treatments is, and therefore enabling us to move from generalised care, where we're extrapolating evidence from randomised controlled trials to a large number of people, to far more personalised care. But not just personalised care in terms of the extrapolation of that evidence, but personalised care in terms of supporting the preferences and choices towards outcomes that matter for that individual. And focusing on meeting true need by identifying that symptom burden and thinking about how we can develop new models of care and direct our resources to prioritise that greatest need first. And so that brings me to the end of the presentation. Thank you very much for listening. I am going to move across now to my chat to start some questions. I think we've got plenty of time for questions, and it looks like we have quite a lot coming in now. So the first question I have here, which is topical, is how does the value-based healthcare approach relate to the current COVID environment? Hello, by the way, I think you can now see me, which is always slightly disconcerting. COVID had a very interesting impact in Wales and the value-based healthcare work here, in that initially it paused completely as we were all redeployed back to support the COVID effort. But actually then we saw an acceleration because, of course, the digital communication with patient work accelerated massively, remote consultations, and also an interest in using patient-reported outcome measures as a way to understand symptom burden in patients who were not able to be seen face-to-face. The second thing I would say about a value-based healthcare approach in relation to the pandemic is I can't see any other way out of the pandemic in terms of post-COVID recovery if we're not focusing on high value and really prioritising what matters the most as we start to recover from the pandemic. So I would say after an initial pause, it's full steam ahead on the value-based healthcare approach. The next question I have here is, what things should be considered when choosing a PROM for a condition? Our approach in Wales is for the clinical networks to lead this so that we get clinical consensus alongside patient involvement around what matters most. Usually it's a fairly straightforward task in picking one generic quality of life questionnaire and one more condition specific questionnaire which looks at the symptom burden. Again, taking into account issues of burden of measurement, which I mentioned earlier, because you don't want people to be overloaded with too many questions. Sometimes less is more. When we have that consensus, we sort out the licensing and, for us in Wales, the translation issues to enable clinical teams then to start to deploy these PROMs on the ground. But it really, I can't emphasise enough, it needs to really make sense for excuse me, for direct care, because if it doesn't, then it really doesn't work, and you won't embed the practice at all. So I have a question here around, has there been any feedback from patients around the technology that is required for them to be able to complete the forms and digital capability, or are they completed with a clinician? This is a great question. When you start any program of work around PROMs, it's highly contextual, so the patient group needs to be considered and consulted with it in some depth. So I'll give you a couple of examples to illustrate that point. The first piece of work we did in the Aneurin Bevan Health Board in South East Wales was in Parkinson's disease patients in a clinic setting, and they were asked to fill out the form immediately prior to a face-to-face consultation, but not with the clinician. Ideally, these forms should be done by patients supported with their carers or another individual, but not with their clinician, to avoid any unintentional bias which can creep in. For our patients living with Parkinson's disease, we were actually surprised, I guess, that despite often quite significant levels of disability, that patients wanted to and were able to do this, and found it a really useful exercise from the off in terms of changing the power differential in the consultation by enabling them to prioritise what they wanted to discuss and lead the conversation based on the PROM that they'd just completed. We needed to make some adjustments for them in increasing the button size, for example, on an iPad, but it was absolutely possible. in terms of user research, when you're wanting to do this remotely, as you will need to and want to for a range of purposes, not least because of volumes of patients, then that user research is more involved and takes a little bit longer. Otherwise, you start to see a drop off in response rates. So a good example would be in orthopedics, where you're looking at the success or otherwise of a procedure. If patients receive a random questionnaire without expecting it 6 months later, then your response rates are going to be much lower. And so people need to be prepared that this is part of their normal care, and they need to be communicated with around the results. Feedback is absolutely essential. Both patients and clinicians say this is absolutely pointless unless they feel that the information is being used and that they're not getting any sort of regular feedback from it. So those would be the sort of main observations I would make about that. There's a question here about information governance. Yes, I'm sorry, Hayden, I think you had a poor connection at times. I didn't focus on information governance during the talk, other than a cursory mention of it, but it is absolutely essential. Of course, as with anything else, people need to understand how their data is going to be used and to consent to that. And a lot of attention has been paid to that in our work here in Wales. My personal opinion is that what we need to move to is a situation where patients have much more control over that data and how it is shared and who with, you know, through a patient portal. And I know a number of systems are doing that very well, and we have people in Wales using that type of approach. As we scale that up, I think that will start to make things easier in terms of the information governance issues that you raised. So I hope that's answered your question, but it is really important, clearly. There is a question here about vendors. So are there any particular vendors who have been useful either in integrating with EHR, that's the electronic health record, or having flexible systems with inbuilt data analytics? So yeah, this is a really rapidly evolving field, isn't it? I can remember when I first started looking at this about 4 years ago, the work was very much less developed, and there were far fewer vendors doing this. So it's been a rapid acceleration, and even more so over the last 18 months or so. Many vendors really do want to integrate. The difficulty that we have is that there are multiple vendors. So what we want to do in Wales is move to open architecture, and that's why it's so important that we develop those common data standards for PROMs in partnership and transparently to enable that interoperability. I'm not a data scientist or a technician, really. I'm a clinician, so I hope I've explained that adequately. Otherwise, my colleagues at home will be cringing. Vendors often do, in fact, usually do have inbuilt data analytics, and that can be really useful, but we don't want that data to be siloed, because that's fine if you're perhaps using it just in direct care, but ultimately to collect data once and use it for multiple purposes, it needs to come into the data repository to be linked with other data and seen in that context. So there's a number of hurdles to overcome there, which is why we really need to work together on that, I think. Next question is, do we have any examples of where the PROM is being used in the consultation, and if so, what impact this has had? Yes, absolutely, and the heart failure example is a really good example of that, particularly for the clinical nurse specialists. and there are now several heart failure nurse specialist teams across Wales who are using PROMs directly in the consultation. The two main effects that they report back to me on that are, first, to really track rapid titration of medication in the early stages of the disease to make sure that that is really optimized. People's symptoms are really reduced, and they did actually, I believe, demonstrate a reduction in hospital admissions in early stage heart failure as a result of that. And secondly, in terms of being a trigger for perhaps a key conversation about moving from really active intervention of the disease into a more palliative phase as patients approach end of life, so that they have more intensive palliation. And again, that can reduce the frequency of distressing hospital admissions sometimes for patients. So lots of impact there, and that's just one example, of course. I'm aware of other examples, particularly in cancer, and actually there's some really good research available now about how PROM use in certain cancers, particularly lung cancer springs to mind, where PROMs have actually improved quality of life for patients in the last 3 months of life. Next question I want to address is a really important one. How do we ensure technology does not drive health inequalities due to populations that need most care not having access to some of the tech needed? Really important question. Digital exclusion is something which needs to be an integral part, I would suggest, of any PROM programme, or indeed any digital health programme. What I would say is that we have found that most people have mobile phones, most people have smartphones now, which is very helpful. And it's interesting to look at the impact of this in low-income countries, for example, on the African subcontinent, where they've basically leapfrogged us in terms of digital health because of the ubiquitous nature of mobile phone technology and how they're using that to track outcomes and also expenditure through the system. So it doesn't have to exclude people, but we always need an alternative, and we need to understand people who don't have access to technology, but also people who do, who choose not to respond for whatever reason. So there's a lot of research that needs to be done in that area, I think. What I would say is that in terms of patient-reported outcome measures and understanding patient outcomes generally, this work takes us on an order of magnitude further than we have been. So it's a really good step forward, but not good enough. And we need to understand that piece about inequalities and not widen that gap further. Absolutely accept that. So where are we going now? Are PROMs completed on the smartphone? They can be, or a desktop, either. There are a range of methods. I suppose it's worth mentioning at this point that when you're starting off a PROM programme, thinking about, really thrashing out all of the reasons why you want to do this and why this is useful will help you then in determining how you're going to deploy that PROM and the range of ways that you're going to do that. There may be some instances where you want to do that face-to-face or even with pen and paper if that's appropriate. Moving on. So how difficult are the licensing arrangements for PROMs, and has it been tempting to develop in-house? Lots of clinicians are tempted to develop in-house PROMs, but the research process for validation of a PROM is really quite lengthy, time-consuming, costly. So generally people revert back to validated tools. Licensing arrangements are variable, so many tools are in fact free and the licensing is fairly straightforward, but there are some that are less so. So when we're selecting a PROM, we take those things into account and tend to go for the ones that are less problematic in that regard, I guess. How are we doing for time? I think we've got 10 minutes, so a few more questions if you're still with me. Is there a platform already available that allows patients to complete consultations and access their full record remotely? Okay, so that's a great question. So is there one system that does everything for patients, including the whole list, I think, that I had on one of my slides? I haven't seen one that does everything perfectly. So there are some systems that are designed just for PROMs that do that exceedingly well and have thought that through really, really well, including some of the data issues that we talked about. There are also very, very good platforms for managing consultations remotely, and there are platforms which share patient information very well. I haven't seen one that is perfect for everything, and I think this will rapidly evolve over the next few years. The important thing, I guess, is that this feels easy and seamless for patients, because what we want to try to avoid is, you know, as a patient having to log into 5 or 6 or 7 or 8 different apps to do different things. I like to think of it as a house. So if as a patient my digital health is a house, I want to go in through my front door with my front door key once, but inside my house I might have a range of rooms that are furnished in different ways, and I may change the furniture in those rooms. So if I've got microservices, micro applications within my house that are my rooms, that's how I like to conceptualize it. It needs to feel like one thing, and it needs to feel very much as though I am in contact with my clinical teams and my healthcare provider, not something remote. And I need to have absolute trust and confidence in how my data is being used. So I think watch this space on the platforms. I think they will evolve further and get much better over the next couple of years, and COVID, I think, has accelerated that. Gosh, lots and lots of questions. Engaging and activating patients, no matter what their health literacy, is challenging. PROM data can become skewed if all patient cohorts not captured. Totally. And that's why we need to be able to link PROM data to demographics, case mix variables, comorbidities, treatment variables, and clinical outcomes, along with other data, because we need to understand when we're analysing PROM data for that type of thing, you know, what are the possible reasons why the PROM data is showing us a particular piece of information, and to be able to put caveats alongside that. It's really important that we don't draw wrong conclusions from PROM data. However, as you will have seen, there are, to my mind, sort of even more exciting ways of using this technique to support direct care and service development, which is really helpful. But it's a really important question, that, and we need to bear that in mind and not oversimplify things. Here's a question about mental health burden. Have we started exploring mental health burden of chronic diseases in addition to the burden of mental health and illness in mental health services? It would be useful to integrate these using quality of life and rater analysis when developing PROMs. Absolutely. So I didn't talk it through, but you will have seen on one of my slides an indicator around mental health in heart failure patients. So many of the standard sets for outcome measures, for example, that developed by or brought together by ICHOM, the International Consortium for Healthcare Outcomes Measurement, often does include at least a screening questionnaire for mental health issues in chronic disease, because the burden of mental health issues in people living with a chronic condition is very high. Frequently 30% in some of the data that we have, but the caveats are around that, as we think that's probably an underestimate based on the cohorts that we've looked at. Really important to understand when we're developing services. I really need to pick up before the end of the presentation primary care, given that that's my background. So what role does or should primary care clinical systems have in creating a seamless data landscape for extending this approach across Wales, or indeed anywhere, I guess? And of course that's a tremendous challenge for us, both in terms of data sharing, which I don't think we have really sorted out in Wales between primary care and the rest of the healthcare system, but also in terms of how patients experience that in terms of their overall healthcare across the whole spectrum of care. So primary care clinical systems need to become completely embedded in this, and I think that the first step to that is to start sorting out some of those data sharing issues which have been a bit of a barrier, given that we can start to demonstrate the value of this in direct care, and I think that should become possible now, and I know that many GP colleagues in Wales and further afield are very interested in doing that. And I think can I do one more question? Okay, so the final question I'm going to look at is on value-based healthcare, and it is, how can value-based healthcare move up the board agenda? Well, I think that what value-based healthcare does, if you have the right conversation, is bring together the multidisciplinary team in a way that other methods haven't, perhaps. So you need your clinicians, your financial and operational managers, and your informatics professionals in a room together here and understanding the benefits of taking this approach. It really does help us with that common language. And we're facing real incredible challenges with increasing costs, increasing pressure on staff, and you know, a greater burden of disease in society. And I can't think of another way to tackle this issue together. So bringing that MDT together, aligning clinical, financial and digital strategy is absolutely key. And I think that's how we move it up the board agenda. There's lots more questions here, so I think I'm right in saying we're able to provide written answers back to delegates, which we will endeavour to do over the next week or two. I haven't seen how many there are, but we'll do that as quickly as we can. And I'd like to thank you very much for joining us this morning, and promote to you the rest of DigiLeaders and also Value in Health Week. You can see the link here. And a lot of the work that I've been talking about will be showcased over the coming week, depending on your particular interest. Thank you very much once again, and look forward to seeing you in the future.